Welcome to Pioneer Human Services Suicide Screening Procedure Training conducted by Jacqueline Darrow, Mental Health Training Manager. Today we are going to overview the Columbia Screening Tool as well as give you information about the suicide screening procedure, and lastly, talk about some general conversation rules when talking to clients about suicide. The reason why you have all been asked to take this training is because there has been a need for continued structure and a need for Pioneer Human Services to have similar forms and similar procedures across all programs. In order to familiarize everyone with those procedures, this training is being taken place so that staff can have an understanding of what and how to complete the Columbia scale, as well as develop an understanding and comfortability in having a conversation with clients about suicide prevention. This was first given to the outpatient clinics in August and is now being prepared and administered for the residential units. Our hope and plan is that in this first phase, we will teach staff how to use the Columbia Suicide Screening Tool. And then in the future, we hope to also train staff in how to use the risk assessment. This is an example of the Columbia scale. We determined to use the Columbia scale because of its vast amount of evidence behind using the scale. The scale is currently used by primary care physicians, hospitals and ERs, as well as social workers and licensed mental health counselors in the private sector. The Columbia scale is in two versions. There is the long version, and there is also the short version. Pioneer has decided to adopt the short version because it can be used generally by any staff member who plays a key role in contact with clients on a daily basis. The Columbia Scale short version is 6 questions, color-coded by risk level, as well as the number in which you get determines what you are to do as a staff person. The Columbia scale is currently in Credible under the headline of Columbia Severity Scale. We also plan on making this Columbia scale available as a paper copy. We are aware that there are certain staff who do not have access to Credible, and so we want to make sure that we have a copy of this Columbia scale in paper form so that it can also be utilized by staff who do not have Credible access at this time. We hope that the staff will utilize this scale every time they are in conversation with a client and a client is expressing suicidal ideations and/or self-harm behaviors. This scale is primarily used by the clinical team, but our hope is that once we have resident treatment specialists take mental health first aid, that they will also be able to administer this Columbia scale. The youth and adult mental health first aid courses will hopefully be offered in the new year so that the resident treatment specialists have an opportunity to take the course so they can get and gain more confidence in having conversations with clients around suicide prevention. The Columbia Scale Incredible doesn't look exactly like this, but it's very similar. This example that you see is the example taken from Google when I Google Columbia Scale. The one Incredible looks very similar to it, just missing some of the format pieces. As you can see, the Columbia Scale is in 6 questions. Based upon how you answer those 6 questions, determine what you are to do as a clinician moving forward. Questions number 1 and 2 are in yellow, posing the lowest risk for an individual. Questions 3 are in orange, 4, 5, and 6 are in red, though half of 6 is also in orange. The risk level is yellow being low risk, orange being moderate risk, and red being of high risk. Based upon how you ask and answer questions 1 and 2, determine what you are to do with questions 3, 4, 5, and 6. Question 1, have you wished you were dead or wished you could go to sleep and not wake up? A client can answer yes or no, and this is based on the past month. If a client answers yes, you ask question number 2. If a client says no to question number 1, there's really no reason to continue doing the Columbia Scale at this point. But if a client says yes, then you ask question number 2. Have you had any actual thoughts of killing yourself? If a client answers no to this question, you skip questions 3, 4, and 5 and only ask question 6. If a client says yes to question number 2, you then ask questions 3, 4, 5, and 6. So again, if you answer no to question number 2, you skip question 3, 4, and 5 and only ask question number 6. If a client says yes to number 2, you ask questions 3, 4, 5, and 6. If you notice, by looking at the questions, you see that the questions build upon each other and get more deeper into thought, plan, means, and action with regards to an individual's attempt to harm self or have suicidal ideations. Questions number 3. Have you been thinking about how you might do this? This question is asking whether or not a client has thought about a type of plan at this point. Have they thought about how they might end their lives? This could include things like medication, stepping in front of a car or a train, or stepping in front of traffic, hanging oneself, or killing oneself with a gun. If they answer yes, we go on to question number 4. Have you had these thoughts and some intentions of acting on them? This is a deeper understanding of an individual's plan. Are they now intending to act upon the plan that they have thought of? If they say yes, you go on to question number 5. Have you started to work out the details of how to kill yourself? Do you intend to carry out this plan? Again, another question to dive deeper into an individual's plan. Are they now pulling and putting things together in order to carry out the plan of killing themselves? Have they started to acquire the necessary tools in order to follow through? Number 6, have you ever done anything, started to do anything, or prepared to do anything to end your life? This is a two-part question. The first part having to do with their lifetime. This is to gain an understanding of whether or not a client has a past history of attempting to take their own lives. The reason why this is important is because we know that if an individual has a history of taking one's life, there is a possible likelihood that that risk may return later in life. So it's important to understand whether or not they've had a history. If they say yes, or even if they say no, you still scratch that. If they say yes, you ask if they've had these same thoughts in the past 3 months. If they say yes to that question, it typically is a risk that an individual has plan, has access, has means, and plans to carry out an attempt at taking their own life. So you could potentially get a score of 1 or a score in between, or you could get a score as high as 6. 6 being the highest that a person could get, giving you the highest risk possible. Scores are very similar to the colors in which a person might also get. If you answer yes to 1 and 2, but answer no to number 6, you still remain in that yellow of low risk. If you answer yes to 1, 2, and 3, but no to 4, 5, and 6, then you're answering more in the orange of moderate risk. If you answer yes to 1 and 2, 3 and 4, and even if you answer no to 5 and 6, you're still in that red, which is considered a high risk. As you can see from down below, you see the colors are then associated with what you need to do as a staff individual. If a person is answering in the yellows, so getting a score of 1 to 2, they are in the low risk. And typically what we're asking is that an individual has continued check-ins as well as a follow-up plan. We also ask that that information is shared amongst the team, either in a progress note or also potentially in an email or a consultation that the staff have with one another, so that all staff are aware of a person's potential plan and risk level. If a person is answering into the orange, this would then need to include a consultation with a supervisor to determine if remaining in the orange or moderate risk is where a person should be, or if it should be raised to a higher risk based upon the conversation you have with the supervisor. We also would like that a safety plan be developed and always a follow-up. This also includes a progress note as well as conversation and an email going out to the team so that the team is also aware of the client and where they are with regards to their risk. If a client is in the red and they cannot complete or follow through with any type of safety plan in place, this will then mean that one will have to connect with the local crisis responder, because outside help will need to be included. That outside help may be including transportation of that individual to a hospital. In the procedure, it goes into greater detail with regards to what is to be done. If an individual is scoring a 1 to 3, so in that yellow or low orange, that individual at that time will need a progress note, a conversation that is disseminated to the team, as well as visual checks every 30 minutes until the situation is resolved. At 24-hour cycles, a new Columbia scale will have to be administered to that client to determine where the client is with regards to risk. And every 24 hours, that will need to be done until the risk is resolved. If a client is in the 4 to 6 range and they are okay with completing a safety plan, those 30-minute checks, visual checks, will still need to happen. And 24 hours, a safety plan and a redo of the Columbia scale will also need to be done to determine whether or not that risk level has decreased. And this will need to be done until the risk level is resolved. If a person is in that 4 to 6 range and they are not able to complete a safety plan, or it is determined that the risk level is too high and that outside resources need to be obtained, that client will need to be in Sightline until EMS or transportation is arranged. That Sightline will have to be in person, meaning the client could not just be in a room with video monitoring happening. The Sightline has to be visual and it has to be maintained by a staff person until transportation is arranged and that individual is transported to hospital. This current procedure is in its finalization at this point, and once completed and voted upon by directors, it will be disseminated to the staff so that the staff can then have a walkthrough of the procedure and a greater understanding of what is being asked of them. This procedure should be put in the binder with the paper copies of the Columbia scale so that staff have a reminder of what to do when a client is in crisis and potentially having suicidal or self-harming thoughts. What we are going to do now is have a brief conversation about suicide and how to prevent suicide. One of the first things that we like to do, or I like to talk about, is certain myths around suicide and how we as staff members can prevent suicide and prevent self-harm. Suicide is a very difficult conversation to have with clients. And in order for all of us to build a better sense of comfortability with talking about suicide with clients, it is in this reason why we go over some of these myths so that we can help build your confidence and your comfortability in order to continue to have conversations with clients about suicide. The first myth is talking about suicide is a bad idea and can be interpreted as encouragement. What we know about this is that currently there is still a widespread stigma around suicide. Not only suicide, but mental illness. Most people who contemplate suicide do not know who to speak to, and so in a sense they keep it to themselves. We want to change that. We want to encourage conversation with clients about how they are thinking and feeling. And in doing so, talking openly about how they're thinking and feeling can give them other options. And more importantly, it helps to prevent suicide from occurring. Another myth about suicide is that once someone is suicidal, they will always remain suicidal. The fact is that heightened suicide risk is often short-term and situation-specific. While suicidal thoughts may return, they are not permanent. What we know about suicide is that suicide is often closely related to situations in which that individual is placed in, putting them in a place of feeling an excess amount of crisis. And again, those thoughts are very situation specific and often very short term. So again, when we have that ability to talk with clients about how they're thinking and feeling and bring and shed light upon those thoughts, it creates trusting relationships and it can create prevention of suicide behaviors. Someone who is suicidal is determined to die. Suicidal people are often very ambivalent about living or dying, so encouraging them to talk about how they are feeling is important. When we have conversations with clients about how they're thinking and feeling around wanting to die, wanting to harm themselves, or no longer being here, it creates a sense of trust, vulnerability, and openness, which is very important in the ongoing process of prevention of suicide. Most suicides happen suddenly and without warning. The fact is that the majority of suicides have been preceded by warning signs, whether verbal or behavioral. Of course, there are some suicides that will occur without warning, but it is vastly important to understand what the warning signs are and to look out for them. Here are some signs that we can all look out for to determine whether or not an individual may be suicidal. When we see all these signs, they are often also closely related to symptoms that a person might be experiencing associated with mental illness or substance use. What we need to remember about seeing these signs is determining whether or not they are dramatically or drastically different than how a person presents in their normal day-to-day life. It's very important for all of us to get a sense of our clients, to get a sense of what they are on day-to-day levels, so that we can determine whether or not an individual may be experiencing a sign that they may be suicidal. Some of those signs may be verbal and some of them may be behavioral. And it's really important that we as a team are in conversation with one another and are consistently consulting with one another about the clients that we share. Oftentimes, an individual may not show verbal or behavioral signs to just one individual. They may actually show verbal and behavioral signs to several individuals. And if those individuals don't talk to one another, it's hard to determine whether or not an individual may be suicidal. So again, it's very important to pay attention to these signs, specifically if these are a drastic change from a person's normal day-to-day behavior. So things like threatening to hurt or kill themselves, looking for ways to kill themselves, seeking access to pills, weapons, or other means, talking or writing about death, dying, or suicide, acting recklessly or engaging in risky activities without thinking, feeling trapped like there's no way out, and having no reason for living, no sense of purpose in life. These are probably one of the most observant signs that a person may display. They may say them verbally, they may also write them down, and we need to be aware and listen to when individuals say these things and take the necessary steps in order to do what is necessary, which would be completing the suicide screening scale. Other signs like hopelessness, rage, anger, anxiety, agitation. Again, a lot of those signs are very closely related to potential mental illness and or substance use that a person may be experiencing. It is in our best interest at this time to be able to pay attention to whether or not those symptoms are increasing at a level that is outside the norm of a person's day-to-day life. If it is dramatic, then we need to pay attention, because that may be a sign that a person is suicidal. So how do we start having the conversation with clients about suicide? We want to be able to start having the conversation, being able to be vulnerable as a clinical staff person, or even as a staff person who comes into contact with clients on a daily basis. We need to be able to be comfortable enough to start having a conversation about individuals' thoughts and feelings when they are brought to our attention. We also need to be aware of our own attitude about suicide. We have all gained throughout the years morals and values and beliefs about suicide. And we need to be careful that when we are talking with individuals about their feelings and their thoughts, that we are aware of our attitudes about suicide, and that those attitudes are not being expressed in either a verbal or nonverbal way to a client. We need to listen and encourage clients to share. This means using our active listening skills, which we will talk about in greater detail in a little bit. We need to ask the individual what they are thinking and what they are feeling. And we need to reassure them that what we hear is okay, that we aren't shutting them down or saying things to them to make them feel less than, that we are validating their thoughts and their feelings without judgment, that we listen openly, that we pay attention, and we give them our full attention. What's most important is to be able to ask the question in a direct way. When we ask the question in a direct way, it's harder for the client to say an answer that is not fully thought out. Asking questions in a direct manner in some ways force the individual to answer in a direct manner. When we ask it in a long-winded sense, or not utilize and use the word suicide, it in a way gives the client a way out of answering the question. It is very true that when we ask the question about suicide, that we may feel panic and shock because this individual has just disclosed something very important to us. And it's really important for all of us when hearing the answer of a potential yes, I am thinking about killing myself, that we do so in such a way to appear calm, confident, and empathetic. I like to think about a swan on a pond. We need to look calm and confident in our face. But that doesn't mean that our little legs aren't rapidly paddling as fast as they can. Because our brains at this point are thinking about what are the next steps? How am I going to prevent this individual from taking their lives? How am I going to prevent suicide? So it's okay to feel that anxiety and shock, but it's best to be able to show in your face a calm, confident, empathetic face. Here are 2 ways in which you can ask the question about suicide. Either ask, are you having thoughts of suicide, or are you thinking about killing yourself? It's important to ask these questions directly. When we ask these questions in a direct manner, it doesn't lead us to asking the question in a potential leading or judgmental way. For example, saying something like, "You're not thinking of doing anything stupid, are you?" By asking it in that way, you are not only leading in your question, but you are also leading with judgment. Even if you were to take out the word stupid and just say, "You're not thinking of doing anything, are you?" Again, is leading the question as well as adding judgment to the question. By simply asking, "Are you having thoughts of suicide?" or "Are you thinking about killing yourself?" you are asking the question without leading and without judgment. I encourage all of you to practice asking these questions. You can do that in a number of ways. You could practice with your supervisor in such a way by you asking the question and your supervisor just listening and not responding. Or you could ask the question in front of a mirror, or potentially ask the question in front of your partner, or your dog, or your cat, or a stuffed animal. What I'm really getting to is that it's really important for us to start creating muscle memory. In order for us to better recall these questions when it is time to ask them, one needs to practice asking the question. That is how our brain and memory works. If we aren't used to asking the questions, we may instead asking it in a judgmental or leading way. So in order for us to start creating memory and being able to recall this question in a time of need, it's best to practice the question so it starts to be put into your brain as a memory recall. So I again encourage all of you to practice asking this question so that you can start having it placed into your memory recall. Some of the ways in which we can be better listeners. A lot of these tips are things that we already know, but I think it's a good reminder for all of us to pay attention to these tips at this point, because we often need reminders about how to be a good listener. Being a good listener means being patient and calm when a person is talking about their feelings. This includes things like listening without judgment, accepting what they are saying without agreeing or disagreeing to their point of view, being able to ask open-ended questions to find out more about their thoughts and feelings. You can show that you are listening by summarizing, by clarifying, by reframing and rephrasing what an individual is saying to you. It's very important at this point when an individual is talking about their thoughts and feelings about suicide for us to be our best and to be good listeners so that we can express empathy for that person when they are telling us how they are thinking and how they are feeling, by giving them our undivided attention without distraction. So if it's best that you pull this person aside and speak to them in a quiet place, either in an office or in a more quiet section of the building, please do so, because for a client to share these thoughts is very difficult for them, and they are trusting you with the information that they are sharing with you. Because again, remember, part of an individual's thought process around these suicidal thoughts and or self-harming behaviors is around ambivalence, this feeling of not wanting to live or die, but just wanting to talk about how they are feeling and thinking, so that we as staff individuals can help the client with a safety plan, as well as help the client in the future of developing interventions for them, possibly when these feelings and thoughts resurface. Some of the things that we should not do when listening. We never want to argue or debate with them about their thoughts. We never want to tell them that what they're thinking and feeling is right or wrong. We never want to use guilt or threats by telling a person that they could go to hell or that they could ruin their children's lives or their loved ones' lives. We don't want to minimize what they're telling us. We do not want to use words like, don't worry, cheer up, you have everything going for you, or everything is going to be all right. The reason why we don't want to do that is because we can't promise the future. For a client, today may be the worst day of their lives, and tomorrow may be the worst days of their lives. So by saying something like everything's going to be all right is in a sense promising them something that we cannot promise. Tomorrow may be just as bad as today. So this is why we do not want to utilize words like cheer up. We want to instead say things like, I see you, I hear you. What can I do for you in this moment? We also want to refrain from interruption, disruption, or telling them stories about our own struggles or struggles that other individuals whom we have worked with in the past. This is not about other individuals. This is about the client and how they are feeling and how they are thinking. And this is where the focus needs to be. We want to also not communicate any negative attitudes through our body language. So paying attention to how you are standing, how you are sitting, where are your arms, what are you doing with your hands, what are you doing with your face. Pay attention in this moment. We also do not want to call their bluff or dare an individual to just do it. We also want at this time to refrain from diagnosing. We have to be careful with diagnosis at this moment because there are several individuals who have suicidal thoughts and feelings who do not have a diagnosis. It is true that suicidal thoughts and feelings are very much tied to specific mental illnesses, but they are not always tied to specific mental illnesses. And so, again, it's really important to keep them separate at this moment and just focus on how the person is thinking and feeling and what we can do to help prevent suicide from occurring. We also want to use the word suicide. Do not avoid using the word suicide. It is important to discuss the issue directly without dread or expressing any type of negative judgment. Again, this goes to one of the first points that I made. When we talk about suicide, when we allow a client to be vulnerable and to share their thoughts and feelings, we are building that trust. And in the same way, we are reducing stigma as well as preventing suicide from happening. Again, an overview of the Columbia Scale is as follows. The Columbia Scale is to be used by all staff who come into contact with clients on a day-to-day basis. At this point, we are asking that the Suicide Columbia Scale be used primarily by clinical staff, mental health staff, SUD staff, nurses, primary care physicians, psychiatrists, psychologists, ARNPs. At this time, resident treatment specialists, certified peer counselors are not going to be asked to utilize the Columbia Scale. We do hope that those staff will have the opportunity to be trained in mental health first aid. Once they have completed the training of mental health first aid, they will also be allowed to use the Columbia scale. We did want to have the opportunity for the certified peer specialists and residential treatment specialists to at least see the Columbia scale at this time so they know what it looks like. But again, at this time, the Columbia scale is to be utilized by clinical staff only. In the future, once residential treatment specialists, certified peer counselors, and any other non-clinical role has taken youth or adult mental health first aid, they will then be allowed to utilize the Columbia scale. The Columbia scale, again, is located in Credible. We also will be giving residential and outpatient units the Columbia scale in a paper form that they can keep for themselves, but we also encourage programs to have the Columbia scale in a binder that is readily available for staff to utilize, as well as also having the procedure there so that they have some direction in what steps to take. Again, you saw that the Columbia scale was 6 questions. The first 2 determine how far you are to go with questions 3, 4, 5, and 6. If you answer no to question number 2, you only need to ask question number 6. If you answer yes to question number 2, you need to ask questions 3, 4, 5, and 6. And again, based upon the number of yeses you get, determine what your next steps are to be. 1 to 3 is more of a yellow, low orange. 4 to 6 is more of a high orange or red. Yellow is going to be consistent with a 1 to 3, which is a check-in and a follow-up with the client, as well as for residential specifically, this will also include every 30-minute visual checks of the client, and after every 24 hours, a new Columbia scale will be administered to determine risk, as well as the development of a new safety plan if necessary. If a person is in that 4 to 6 and a safety plan is administered, again, that safety plan will have to be re-looked at every 24 hours until the situation is resolved, as well as completing the Columbia scale to determine where that person is with regards to risk, as well as 30-minute visual checks of that client, again, until the situation is resolved. If that client in that 4 to 6 range is unable to complete a safety plan, and it is determined that the risk is severe and high enough, then that individual will have to be maintained at a visual check in person. That individual cannot be in a room with monitoring, video monitoring. That person must be maintained in the same room with visual checks until transportation is arranged and that individual is transported to a hospital. If anyone has any further questions about this training, please feel free to reach out to me. I am located in the address book of Pioneer Human Services under Jack Wolandero. Thank you, and have a great rest of your day.